Yeah, thank you very much. I would like to talk about the basics of PCD, why the cilia are not moving correctly. I will start a little bit with the history, because in the beginning, nobody even knew that cilia were the problem, because people didn't know that the cilia were there. But still, the symptoms together have been observed. So in 1904, there was first description of the joint occurrence of bronchiectasis and status inversus by Siebert. And later in 1935, there was a name-giving publication from Switzerland, from Zurich, from Dr. Manes Cartagena, who died in 1975. And he described more than 4 patients with status inversus and recurrent sinusitis and also bronchiectasis together. And still, people didn't know about why this syndrome was happening, because they didn't know that they were the cilia. So in the 1960, there was also the male infertility as additional symptom discovered. And then in 1975, finally, it was understood that there was a cilia, and also discovered by a structural defect of cilia in a sperm. So this was like the way this was discovered. And then in 1981, there was the introduction of the nomenclature PCD. I didn't translate this, I'm sorry, it's German, but primary ciliary dyskinesia by Slay. And then 2005, there were the first publication was focused on PCD genetics. And then 2013, first guideline for diagnostics of PCD. We will hear more about this in other talks. And then 2012, the first European joint research project and making better care, the cilia started, and then BEAT-PCD came, and the EN lung, and the clinical trial network. And finally, in 2022, we can say that they are first causative therapies for certain types of PCD in preclinical development. You will also hear more about this, but I think it's just so great to see that science took on. And even though it's very complex, the background of PCD, because it's I will explain this, many different proteins can be involved. Still, we are at the time point where it actually might get possible to have causative treatments for certain types. So the disease PCD is, this was the title of my talk, because the cilia, why are the cilia not moving correctly? This is respiratory cilia. It's like protuberations of the cell membrane. You know, the cell has like a membrane around it, and then it's protuberates out. And in this membrane protuberation, there's a cytoskeleton that has very special features and can make the movement. And so what do cilia need to beat? They need, as I said, the cytoskeleton. I will explain this in the cilia, and it needs motor proteins that make the movement, and it needs, of course, energy and also regulation, and the whole thing needs to be anchored with the basal plate in the cell membrane. So it's a very complex organelle, if I want to put it this way. And if you compare it to cystic fibrosis, it's just cystic fibrosis has just one channel that is defected. Here it's a very or comparatively big and complex thing. So what happens when cilia don't beat properly? If you look in the upper image, you see ciliated cells that say they are from the bronchus, and then the green is a goblet cell, a secreting cell, and you see the cilia that do their beating, and then the airway surface liquid, like the normal, the healthy mucus. And this function is like all around 24/7 to move out everything that comes in, even if it's bacteria or virus or fungi or just dust. So everything is moved out of the upper and lower airways. And when the cilia are not beating properly, in a lower image, then you get more goblet cells, you get more mucus, you get pathologic mucus, like everyone knows, you expectorate it. And then the the bacteria and germ and other problems and things that can disturb don't get moved out properly, and you get, as seen here also in the bronchi image, a chronic bronchitis. So basically, when the cilia don't work, all of the patients have to more or less extend the chronic bronchitis. And if you look at this here, in another image in a normal situation, and then a normal bronchus, that's a bronchoscopy from a human. And then when you look on the lower image, you see when you have severe PCD, there's lots of bacteria, lots of mucus, and you have edema in the mucosa, and also a purulent secretions, meaning that there's a lot of bacteria and also defense cells that actually are there to eat the bacteria, and they form the pus. And this is like the typical situation when let's say when a patient has an exacerbation, but there's always bacteria and always inflammation in the bronchi. This is an image, PCD is not in it, but it compares like from healthy disease over asthma, COPD to cystic fibrosis, what the situation is like in the bronchi, and PCD is somewhere between severe asthma and COPD. And just to show you that it's like a spectrum, and that the amount of mucins and inflammatory cells it gets more and more the more severe the muco-obstructive. That's like the over term for those diseases, which PCD is one part of, are in place. So concerning the anatomy of the cilia, you know, I explained that they are what they are there for, but now how do they work? There's many components, but there's always 9 double tubulus pairs and 1 central pair, and then you have motor proteins, and the green here is the outer dinoine arm, and the orange is the inner dinoine arm, and the energy put into especially the outer dinoine arm makes the cilia move with shear powers, and the inner dinoine arm also is a motor protein, but it's more for regulation. And then you have also other structures that are important. I'm telling all these structures because in all of them you can have defects, and all of them can cause PCD in different forms. So the radial spoke, the central pair, and the next scene link are also components that are important for the cilia to work. And to make it go a bit more into detail, that you need it's specialized proteins. For example, for the outer dinoine arm, there's DNAH5, DNAH11. Those are all genes and proteins that are important for the proper beating, and also for example, pre-assembly factors. That means it's not in the cilia, but when the cilia proteins are composed, it's needed to make them, and they lead, for example, to inner and outer dinoine defects. And then there's the axonal merula, which is very important for the composition of the cilia, that it's built correctly, and when it's not there, it's not built correctly, or radial spokes. So there's already discovered a lot of proteins that are necessary to make a human cilium work properly. And as I said, all of them can have defects and cause different types of PCD, and also not all of them can cause situs inversus. That depends on the protein. For example, the outer dinoine arm proteins, they can cause situs inversus and Cartagena syndrome, but radial spoke, for example, cannot, because it's a different cilium that is needed for the left-right alignment or the asymmetry, and not all of the proteins are needed in that cilium. So that is a lot of things we have understood, and this is very important because when we understand exactly the pathomechanism, how things come, we can start think about causative therapies, and this is, as I said, we are moving in that direction at the moment. So from theory, I would like to show you cilia. This is a sample of a healthy human. You see it's like a whiplash, more or less, and beating quickly and coordinated. And you see that in this is outside. This is a cell from the nose of a person, And you can see that even the whole thing starts to move because the cilia work correctly. So this is always a sign that the cilia are working. And this is another example of a autodynein defect, DNAH1, and you can see that the cilia are hardly moving at all, and also the cell is not moving. So I think it's pretty clear that you can see without experience that the mucociliary transport is not working here. And the next one is an outer and inner duodenum defect. And it's not that the video is not working, but it's just that the cilia are not beating at all. Also, this can be the case in certain defects. And this is an example of the axonal ruler, like that's also called microtubular disorganization. Those are patients that have the more severe causes of disease. And I would start the video, and you see that they beat quick, but they beat stiff, and the amplitude is very low. So there's no effective transport on the one hand side, and on the other hand side, like with a brush, the cilia are sticking in the lumen of the bronchi and prevent the mucus from being moved out. And then there's DNH11, which is interesting because cilia beat too fast. They don't beat right, but they also beat faster than they should. I hope you can see that. And those are patients with milder causes of disease because they have a residual function of the mucociliary clearance. So there's a big variety of defects that cause different things. And also there's types where you don't have cilia at all, or other ones where you have not enough cilia and still the function is impaired. So to wrap it up, the disease PCD is a rare inherited disease. We know at least 53 genes that are involved. Most of them are autosomal recessive. That means that two healthy carriers, parents, can have that one quarter of their children have the disease and 3/4 don't have the disease. And it's a dysfunction of the motor cilia, and for example, it can be a wrong movement of the cilia in the airways or no movement, as I just said. So we're not talking about one disease, we're talking about a group of heterogenic, rare inherited diseases. And the incidence is estimated by 1 in 7,500, more than we thought. But when you look for things, you find them. And the self-cleaning of the mucosa is impaired, and symptoms are, as you all know, chronic productive cough, bronchitis, chronic rhinosinusitis, so nose problems, and ear problems, and also hearing impairment, nasal polyps, or reduced fertility. So, and if we go a bit more into detail with the symptoms from the age, if you look at infants, there's one special thing about infants that 80% of the patients with PCD have a respiratory distress syndrome after birth, after normal pregnancy and no birth complications. And this is, I think, a very, very important thing because it's the unique opportunity, a window of opportunity to actually have early diagnosis of the disease. And an early diagnosis, even if we don't have causative therapy yet, can make a much better life because early treatment prevents things. All of our treatment is what we are doing here. And my idea of treatment is not reacting to crisis, but prevent things or preserve the status of the patient. So the earlier we start with it, the better. And also they have recurrent bronchitis or pneumonia, chronic rhinitis and cough since birth. They can have otitis problems because the tube problem, and of course they have laterality defects in congenital heart disease. And in adolescent and children patients, it's more sinusitis starts because the sinus develop, also otitis media, chronic discharge from the ears, especially when grommets have been placed. This is a controversial issue, other people will talk about. Have changing impairment of hearing, and also problems with speech development. But this is data we published this year. The lung disease starts early. Here we compared 4-year-old children in mean with healthy controls, PCD and cystic fibrosis. And the higher the value, the worse is the lung function. And you can see the PCD group is as high as the cystic fibrosis group. even already in 4-year-old subjects. So the lung disease starts early when you have a method to look for it that's feasible. So this is why an early diagnosis and early treatment is important. That's kind of the proof of that concept. This is cross-sectional imaging with MRI from a 5-year-old child that has been diagnosed just a few months before. And for those of you who are not familiar with imaging so much, the black means that's air. That's how the lung should look like. And the white big thing is the heart in the middle in the left image. And then this sail, what you see here, this is a consolidated middle lobe. That means the one lobe, there's a small lobe of the lung is destroyed. And this is very typical in untreated PCD patients that they have this finding. And in the other image, that's the same patient that's in the other plane. You see also lots of bronchiectasis already. And this is just important thing to show that patients with PCD need treatment early. And this is a proof of that. So in adult patients, there's less otitis media, but they tend to have nasal polyps. They have lung function, of course, over the years, a decline of the lung function, chronic bronchiectasis, and progressive bronchiectasis, and chronic bronchitis, and also hearing impairment, and sometimes afertility or reduced fertility in men. I think I already said that. And we look at this older data. I think hopefully nowadays they are better. But these are two different types of lung function, the FEV1 and the FVC, shown over decades of years in patients with PCD, and the black line shows the decline. That is better than CF patients before the new therapies were there, but still a significant decline. The FEV1 is for the obstruction, and the FVC is for the lung volume. So it's a mixed loss of lung volume, but also of progressive obstruction due to the inflammation. So this is the cause of the disease in mean in adults. But if you look at now, we know that if you look at certain genotypes, that some have quite under treatment, even can hold their lung function, and others still decline. It's really not one disease, but it's a spectrum of diseases. But this is like the mean. This is again now not an MRI, but a CT scan from a patient with Cartagena syndrome, and I think it's again the middle lobe now is mirrored to the other side, and it's also destroyed. And what is very typical is that you see the black, the upper lobes. So this is just black. What a lung is supposed to look like. So and this is typical in PCD that the upper lobes are almost spared out. And then you have more problems in the middle and the lower lobes. And what you see when we move to the other image, that's also a cross section, you can see the bronchiectasis and those white rings with the thick white rings. Those are all inflamed bronchiectasis with swollen mucosa. And this shows that there's really a lot of inflammation happening in this lung at this time point. And those white dots you see everywhere, that's called severe tree and bud sign, like a tree that is in bud. And this is also very typical for PCD, and it's not only there when they have exacerbation, but it's always there. And this is like in the lower lobes, it's just mucus in the smaller airways. So this is what it can look like then later in life. So to round it up, we need an interplay of several structural and motor proteins for proper movement of the cilia, or for proper ciliary function. And motor cilia together with mucus have an important cleaning function in the airways. And the impairment of ciliary function and the clinical picture can be very different depending on the affected protein, as I said. And I repeat myself, chronic rhinosinusitis and chronic bronchitis are the most common symptoms. So I hope you have enjoyed my talk, and I think the questions we do later, but I will be very happy to answer questions.
Okay, thank you, Jobst. Thank you for your very interesting presentation and information about PCD. I think we learned a lot. and thank you for participating for this Congress. Now I would like to introduce the next speaker, Professor Amelia Shoemark. Amelia conducts lung research at University of Dundee in Scotland. Her research focuses on improving a diagnosis and therapies for bronchiectasis and PCD. Amelia is one of the chairs of BEAT-PCD, European Respiratory Society Clinical Research, difficult word, Consortium, who aim to raise awareness and improve care for people with PCD. She also works as a clinical scientist leading the PCD diagnosis laboratories at the Royal Brompton Hospital in London. Amelia has more than 20 years experience conducting diagnostic tests for PCD. She has been involved in PCD gene discovery and improving many laboratories-based tests for the condition. It is a pleasure to welcome you to this Congress. The stage is yours.
Thank you very much. Can everyone hear me okay? I'll take that as a yes. Great. So I'm going to talk about PCD diagnosis, as Petra just said. I was going to start off with just a couple of polls. So if Leonie, you could bring the first poll up. I just had some questions, which was, I wanted to know a bit about the audience. So are you a patient with PCD, a parent of a child with PCD, or are you a healthcare professional or researcher? It would be just nice to know a little bit about who we have on the call today. Lots of answers coming in. It seems like we have a really nice mix of people. Okay, we'll stop it there. Thank you. So yeah, about a third of each, which is fantastic. And then my next question was so this is for the patients and the parents, not for the healthcare professionals and researchers. How old were you when you received your PCD diagnosis? And we have lots of options. So under 5 years of age, 6 to 10, 11 to 15, 16 to 20, 21 to 40, or over 40. So most people diagnosed as children, which is brilliant. A high number of people diagnosed over 40 years of age. And a real spread. Okay, thank you very much. So if we stop sharing and I'll move on with my presentation. So following on from that, the average age of diagnosis for people with PCD in Europe last time it was looked at was about 5 years old. So I think we probably reflected that in our poll. But actually, most people with PCD still don't have a diagnosis. And if you look at the number of people that are predicted from genetic studies to have PCD across Europe, and then you look at the number of people that have actually been diagnosed and are in our registries and in our clinics, actually the majority of people still remain without a diagnosis. And that's very important because we're still missing people. And those obviously aren't the people on this call. The tests that we use to diagnose PCD can differ across Europe and can differ across the world. And as a community, we're trying to make things so that you do get more equal care across Europe and equal diagnostic tests. It's also likely that you can't be diagnosed with PCD with a single test. So it's likely that you will have one or more tests to confirm the diagnosis. And the first thing, and many people on the call have already been through this diagnostic process, so I'm kind of already telling you things that you already know, but the first thing a doctor will ask you when you get referred to the right person is about your symptoms that are related to PCD. They're likely to ask you about your lungs, the time spent in hospital immediately after birth, or if there was any, about cough and whether it is wet and whether it is productive, how often you have chest infections that require antibiotics, and also they may do a CT scan to look for bronchiectasis that Jobst just described nicely as the scarring of the lungs. They're likely to also ask about upper airways and whether you have a runny nose, whether you often get sinusitis and headaches. They're likely to ask about your ears and how often you have ear infections and if you've had a hearing test. And then also the position of the organs, and in adults about fertility or infertility. And not all of these symptoms are present in everyone who has primary ciliary dyskinesia. But if you put them together as a picture, it can give you a good idea as to whether the person might or might not have the condition. Sorry, I hadn't realized I'd animated this beautifully. So they might also order other tests which might be the cause of your symptoms to exclude those before they continue with the diagnosis of PCD tests. And they might test for cystic fibrosis. They might test for how your immune system works to fight infections. And they may also look to see if you have asthma. The first test that's often done is nasal nitric oxide. And this is just one example of a machine that we have in the Brompton Hospital where I work. There's lots of different machines, but they all kind of work in the same way, that you put this nasal olive into your nose and the machine sucks out some air into the analyzer, and it tells you how much of this nasal nitric oxide gas that you have. People with primary ciliary dyskinesia in general have very low levels of this nasal nitric oxide gas. And we actually don't know why, but it can be really useful to trying to tease out who has PCD and who doesn't. And this is an example of a trace from the machine. So on the left-hand side here, I don't know if you see my mouse, on the left-hand side here, this is the person breathing, and this is their carbon dioxide as they're breathing. And this is a healthy non-PCD person. You can see the nitric oxide rises up like this. This is someone with PCD. They breathe and then they hold their breath, which is part of the test, and the nitric oxide doesn't rise up. So there can be lots of reasons why that happens, and it doesn't have to be related to PCD. So you could have a blockage in your nose or some other reason why it's low. So we can't stop the test there. And there are also exceptions. So there are people with PCD who do have normal levels of nasal nitric oxide. We also don't know why that is. So this test adds to the picture of all of the clinical symptoms that you have been experiencing and also this result, and tells us about whether to continue with the testing or whether we can exclude it at that stage. If we continue with testing, most people will either do a nasal brushing or a biopsy, and you might remember this. So this is the nasal brushing. It's actually a bit like a COVID test and is much easier to describe than it used to be. This is a little brush. Sometimes people will use biopsies and they can use things that are a little bit like tiny ice cream scoops. This one's more like a mascara brush or a very small toilet brush. And what they do is scrape the inside of the nose a little bit to get some of the cells and the material out of your nose. And that's a good way of looking at what's going on in your whole airways from your nose right the way down to your lungs. And this is a very quick test. It doesn't take very long, but that sample can have lots and lots of things that happen in the laboratory after it's been taken. And quite a few places in Europe now will do this and look at a high-speed video microscopy. So they put that sample under a microscope and they look at the way the cilia are beating. And these are cilia beating and effectively clearing things like they would be out of your airways, moving from left to right and clearing secretions. This is an example of someone with PCD, and you see those cilia, oops, sorry. Actually don't move at all. That video is playing and you can see it shaking a bit, but it's not effectively clearing secretions. And Jobst showed you some good other examples of this, but we use this in the diagnosis because it's a really good way of seeing actually, Are the cilia functioning, and are they doing what they're supposed to be doing? The other thing we do is electron microscopy. So we can take the sample and we can look at each one of those tiny little hairs that you saw beating. You can look at those in cross section. So I don't know if anyone's familiar with rock, which is sweeties you get at the beach. But if you open up a piece of rock, then you get writing inside. And this is like the writing inside the cilium and what it looks like inside. And if you look at the outside and the inside of these circles here, these are the motor proteins. So these are the motors that drive it and make it move backwards and forwards. And we're able to look at these under a microscope relatively easily. And if you have primary ciliary dyskinesia, then often these motor proteins are missing. And so you can look and see whether the motor proteins that make the things beat are there or not. And if they're absent, then that is a indication that you definitely have PCD. So there's an international consensus from America, Australia, and many countries in Europe, where we have 3 very defined things that if you see this finding by electron microscopy, then that person does have PCD. And that's the absence of these dynein motor proteins, absence of just one set of the dynein motor proteins, or this sort of appearance, where, as you can see, instead of this nice 9-fold symmetry structure, there's sort of collapse of all of these microtubules, and also some of the dynein motors are missing. And when we look in this kind of detail at the individual cilia, we also see lots of other things, and they can help us to get an idea as to what else might be going on, but they can't be used to make the diagnosis on their own. And the reason for that is because if you have a viral infection like COVID, or if you have a bacterial infection in your nose, that can also disrupt what the cilia look like. So we have to be careful that we can make the distinction between a genetic finding, which is going to be lifelong, or something that's just short term. And quite often when we ask people to come in for diagnostic testing, we will make sure that they haven't had an acute upper respiratory tract infection or a sort of cold within the last few weeks, to make sure we can try and get rid of some of these secondary defects. One of the other tests that we can do is to look at what we call immunofluorescence, and you might hear this talked about in some of the other talks. And essentially, we take the cells that we've taken from your nose and we look at them. So this is the nucleus of the cell. That's where all of the DNA is stored. This green bit here, this is a stain for the cilia, so it shows you that the cilia are there. And then this red bit is one of the motor proteins. So this is a non-PCD cell. You see, you get the cilia here, the motor proteins here, and when you put it all together, you get a cell with DNA, the cilia, and the motor proteins within the cilia. This is someone with PCD. So we've got a cell there, we've got cilia there, but when you look at the red channel, you can see that there's that stain hasn't gone into the cilia, it's just stuck at the top of the cell, and it's very limited, and therefore that cell doesn't have the motor protein, and therefore the cilia won't beat. So that's another way that we can help to make the diagnosis, and it's also quite useful if we find a gene, because we can look at that gene and say, okay, does it make the protein, and does this translate to the cell? And that moves me on to genetics. So PCD is generally autosomal recessive inheritance, and that means that you have one copy of the gene from your mum and one copy of the abnormal gene from your dad, and that's what gives you the condition. So if someone who is a carrier of a PCD gene and another carrier of a PCD gene have children, then you can have a child who isn't even a carrier. You can have a child who is a carrier of the gene that dad has, a child who's a carrier of the gene that mum has, or you can have someone with PCD because they have both genes. So you need to have a copy from both mum and dad to get the condition. And that means that you have essentially with a sibling a 1 in 4 chance of having another child with PCD. And we're able, when we do genetics, to look at the family and take blood from family members, and that helps us to understand whether the gene we're seeing is causing the disease or not, by being able to associate it with the parents and the siblings. We know about over 50 PCD genes now, and this is a little timeline of when they were discovered. So I started working doing PCD diagnosis in 2001, which is here, and at that time we knew about 2 PCD genes, and there was an awful lot of work that went into discovering those. And over time, more and more have been discovered. And round about here, 2012, 2013 is when next generation sequencing came in. And that meant instead of having to have very targeted look at what might be wrong, we began to get the ability to look more at the whole gene and the whole exome. And therefore, lots of PCD gene discovery was done. You can see that every year there's a few new PCD genes get identified, and so we're learning more and more, and I think that will continue. 2023 there'll be another 3 or 4 PCD genes identified, and at the moment, if we do genetics, we can probably diagnose about 80% of people who have PCD. The other 20%, we're still making a diagnosis on electron microscopy, on the function of the cilia, entirely without any genetic testing. So DNH5 is currently the most common PCD gene, and I just wanted to show you, this is a slightly complicated slide, but I just wanted to show you because I think it's nice to understand. This is the DNH5 gene. So if you think about your genome as an instruction manual as to how to build, I don't know, a car, then each of the genes is a page of that instruction manual, and each of these things is a word in the page. So there's 4,624 words in this page of the instruction manual, and this is to make part of the motor of the car, for example. Each one of these little things is the word that's changed that causes PCD, or in this case, an amino acid. So you see that most people that have PCD due to DNH5 mutation actually don't have the same thing. Most people have a unique variant that's seen for the first time in that person. There's a few things. So this variation within the instructions is seen in about 40 people, but most things are what we call private mutations. And so when we do genetics, quite often we have to follow up with another test because we find that there's a variation in this gene, but we don't know if that will actually cause disease or not, because we have lots and lots of variations in our genes, and that's what makes us all different. So we can't all have exactly the same sort of book or manual. So that's just an example of DNH5, and it's the same is true of most of the genes. There's lots and lots of different variations. And we're starting to understand a little bit more about variations within the gene, but also different PCD genes and how they cause different symptoms. So for example, if you have a variation in one of these genes, the RSPH genes, then you won't get situs inversus associated with the condition. And we also understand a little bit more about what the genes do and what proteins they make, and therefore how the cilia are likely to beat. So these outer dynein arm genes will almost certainly lead to almost completely static cilia. So I think this is my final slide. This is the European Respiratory Society guidelines for the diagnosis of PCD. And this is the guidelines that it's recommended that people diagnosing the condition follow. And basically to get a definitive diagnosis, then you should have one of these electron microscopy structural defects or gene defect, which is present in both parents. That's actually, this was written in 2017, and we now know about some other genetic causes which are inherited differently. There's still quite a lot of people who don't fit this criteria and are considered to have highly likely PCD based on the nasal nitric oxide test and the functional tests showing that repeatedly the cilia aren't beating and moving properly. And excluding the condition is really difficult. So we say that PCD is extremely unlikely in a situation where their history is not strong, the nasal nitric oxide is normal, the cilia ultrastructure and the way that the cilia are beating is normal. And it's also important to exclude a diagnosis of PCD because that allows your doctor to follow up on possible other causes of your symptoms or your bronchiectasis. So I just had a couple of questions to finish. The first one, if Leonie could launch the poll again, is do you know what your PCD gene is, or have you had genetic testing? Because I think this is over the last few years come in more and more, and it's definitely country dependent. It's interesting to see. Obviously, this is a question for patients and parents, not for our healthcare professionals. Great. So about 2/3 and about 1/3 no. Hopefully it will become more and more prevalent with time, and I think it's becoming increasingly important also because of the potential for new therapies and different associations with different genes which are emerging. Thank you. And then finally, I just wondered if anyone in the chat wanted to give advice on others trying to get a diagnosis of PCD. I don't know if there's anyone on the call who hasn't yet received a diagnosis, but there's definitely some cases if you survey and discuss with people where a number of people will access healthcare at least 40 times before you end up in the right place to try and get a diagnosis. Part of what we do at BEAT-PCD is trying to raise awareness so that we can so that doctors are aware of the condition and able to refer people to the right place. Don't know if anyone's not quite sure where this shows up. I don't know if I can progress my slide and it will stay running. Yeah, and then so that ends my talk and I think starts the discussion of this session if anyone has any questions.